to another intensivecarehotline.com live stream. My name is Patrik Hutzel from intensivecarehotline.com. I am a critical care nurse consultant / advocate and consultant for families in intensive care. And today's topic of this live stream is aspiration pneumonia in intensive care. And I want to dive right into it into a minute. I just quickly want to talk for 1 minute what makes me qualified talking about this topic. So I have worked in intensive care for over 20 years in 3 different countries. I have worked as a nurse unit manager in intensive care for over 5 years. I've mentored many critical care nurses when they first entered intensive care. And nowadays I'm consulting families in intensive care all around the world. I'm participating in meetings with doctors, nurses over the phone predominantly, but also in person, depending on where clients are. But nowadays it's predominantly over the phone via Zoom, Skype, all methods that modern technology allows me to do that. And I also run a service called Intensive Care at Home, where we provide intensive care nursing at home for predominantly long-term intensive care patients, adults and children that would be stuck in intensive care otherwise. And we're improving their quality of life at home, and in some instances their quality of end of life at home. So that's why I want to approach this topic today. And I think it is such an important topic when you have a loved one in intensive care, specifically long term, but also in the short term, but especially what we're seeing at the moment as well with COVID. A lot of patients are being they're in prone position. And if they're in prone position, the risk for aspiration is huge. But let's dive right into the topic of aspiration pneumonia in intensive care. Why does it happen? Why is it important to talk about it? It happens in intensive care quite frequently because the risk factors in intensive care are very high to have an aspiration pneumonia. And I'll come to those risk factors in a moment. And if it does happen, it often extends a proposed stay in ICU. I mean, the average length of stay in ICU is probably 3 to 4 days, probably going up at the moment, the average length of stay, because of COVID cases specifically. COVID cases in ICU tend to have fairly long stay because of ARDS, prone position, potentially ECMO, the whole 9 yards really. And that's probably increasing the average length of stay for intensive care patients. So also what happens more often than not is obviously if someone aspirates in intensive care specifically, they end up with an aspiration pneumonia. They might end up septic, they might end up in septic shock. So, the risk for things to go wrong after an aspiration pneumonia is very high. And the risk for a prolonged intensive care stay with antibiotic therapy, prolonged ventilation, potentially sepsis, septic shock, kidney failure, you name it, is there, prolonged induced coma, the side effects of that. So avoiding an aspiration pneumonia is critical. So what is an aspiration? Aspiration is defined as the inhalation of either oropharyngeal or gastric contents into the lower airways. That is the act of taking foreign material into the lungs. This can cause a number of syndromes determined by the quantity and nature of the aspirated material, the frequency of aspiration, and the host factors that predisposes the patient to aspiration and modifies the response. It is an accidental infiltration of food or other substances from the mouth or stomach into the lungs. The condition can be caused by bacteria that normally resides in the mouth or nasal passages, or triggered by non-infectious toxins that damages lung tissue. So the aspiration into the lungs with a subsequent pneumonia is a serious complication frequently encountered in ICU or intensive care units. Aspiration pneumonia is caused by the inhalation of colonized oropharyngeal and gastric secretions and is therefore an infectious process. The problem is complex for aspiration pneumonia. 20 to 30% of patients in the ICU presenting with gastric contrant aspiration eventually develop a secondary infection. Techniques to avoid or reduce aspirations are important in preventing pneumonia and pneumonitis. So what is causing the aspiration pneumonia? So it's characterized by a failure of the physiological mechanism that prevent food and other substances from entering the trachea and windpipe and the lungs. The aspiration, which really stands for drawing in of these substances, can cause inflammation, infection, or airway obstruction. Healthy people will commonly aspirate small amounts of food and other substances, but it's of no harm. Many cases, however, and that's where it probably links in with intensive care, many cases of aspiration pneumonia are linked to either a neurological condition or an episode of impaired consciousness that disables this reflex. And especially when we're talking about neurological conditions or impaired consciousness. So we're talking about somebody in intensive care potentially with a stroke, not necessarily on a ventilator, but often their swallowing reflex is impaired, and that's increasing the risk for aspiration. But also picture this, someone in intensive care on a ventilator, either with a tracheostomy or with a breathing tube in their mouth, potentially in an induced coma. Therefore, their swallowing reflexes are not there. Also, when they're in an induced coma and they are on sedation or opiates or potentially even paralyzing agents, their digestive tract is also paralyzed, which means most patients in intensive care get feeds through a nasogastric tube or through a PEG tube. And if they are in an induced coma, have opiate sedatives, and potentially are paralyzed, their gut motility is down as well, which means there could be a delay or even an inability in absorbing feeds or digesting feeds, hence making the risk for vomit and therefore aspiration, generally speaking, much higher. Right? So again, neurological conditions such as stroke, Parkinson's disease, Alzheimer's disease, MS, multiple sclerosis, cerebral palsy, amyotrophic lateral sclerosis, ALS, myasthenia gravis, and brain trauma injury, for which dysphagia, difficulty swallowing, is a characteristic. So therefore, vomiting during which the severe spasms can allow food to slip from the esophagus into the trachea. Esophagus is also where the feeding tube is going in. Alcohol, sedatives, or illegal drugs which can alter your level of consciousness and disable the normal gag reflex. Critical patients in an induced coma, as I just mentioned before, and coming out of the induced coma. So one thing that I've seen over the years is clearly when someone comes out of an induced coma and you take them off the breathing tube, you extubate them. And the reality is when you do that, patients are not necessarily fully awake. They're still a bit drowsy. And I've also seen that, a lot of patients, when they first get extubated, have the breathing tube removed, they're incredibly thirsty. And I have seen that if you give them water to drink or even ice blocks, it eventually triggers a vomit. And because they've just come out of an induced coma, the risk of them vomiting and then potentially aspirating is real. And the last thing you want is for somebody coming off a ventilator, being extubated, having a large vomit, and then aspirating and going back on a ventilator. I've seen this, and it's tragic if it happens. It sets patients back to the point where they might need, prolonged ventilation, induced coma again, treatment for pneumonia, bronchoscopies. They might end up being septic, in septic shock. They may die, So I can't say this often enough, that the devil is absolutely in the detail in intensive care. And little things that the bedside nurses, the doctors do, are critical, absolutely critical for the well-being of a patient. And if you give them too much water and they vomit, because their stomach is not used to having that stimulation when they come out of an induced coma, could set them back, and you don't want that. Seizures, in which involuntary spasms can promote aspiration as well. General anesthesia, absolutely, which disables the swallowing reflex. Dental procedures, not so much for intensive care, but also definitely gastric tubes and endotracheal tubes, also known as breathing tubes, which provide a ready route of access from the stomach to the lungs, and that is a big risk factor. And also gastroesophageal reflux disease, also known as GORD, characterized by acid reflux and the increased risk of chemical pneumonia. You might say, and also tracheostomy is also a big risk for an aspiration to occur. And I tell you why a tracheostomy as well as a breathing tube / endotracheal tube are such high risk factors for a pneumonia. Whilst both breathing tube and the tracheostomy have a block that seals basically that seals the trachea and also blocks off the esophagus, it should in theory stop from any gastric content, vomit, food, anything go down the lungs. But the reality is this, that even though there's a block, a balloon, there may still be some micro aspiration, and that might be enough to set off aspiration and a pneumonia. Also, other things where aspiration can happen is definitely, again, the risk is there with a nasogastric tube, an upper gastrointestinal endoscopy, bronchoscopy. We talked about feeding tubes. Other types of associated conditions are protracted vomiting, prolonged recumbency, general deconditioning and debility, critical illness. And talking about prolonged recumbency, for example, a lot of patients in intensive care might be lying flat because of their condition, and yet they still need to be fed. They still need to get nutrition. So imagine you're lying flat and you're getting nutrition through a nasogastric tube or through a PEG tube, and then you are in an induced coma. Everything, your body shuts down, your gut motility is down, your digestive system is down. Imagine all of that, and that increases the risk for vomiting. So once an aspiration has happened, how does it happen? How is it diagnosed? It's usually diagnosed with, to begin with, air auscultation with a stethoscope. As you can see, decreased flow of air, rapid heart rate, crackling sound in your loved one's lungs, and oxygenation is going down. Your arterial blood gases might deteriorate, and it's then diagnosed with a chest X-ray, sputum culture, complete blood cell count, arterial blood gases, bronchoscopy, CT chest, and blood cultures. So now we're talking about the critical part, how to prevent an aspiration pneumonia in ICU. So one pattern, and again, I mentioned this before, but I do believe it's so important that I want to mention it again. One pattern that I've seen, you extubate a patient, which is great. You take them off the breathing tube, and they're dying of thirst. They're dying for a sip of water. And whilst you as a nurse don't want to really deny them that water, I can tell you from experience that if you give them water, they start vomiting. The side effects of coming out of an induced coma are there, and then the risk to aspirate is there. And that's why you want to go very slow with water after extubation. You want to start maybe with some ice chips, some very small ice chips, and maybe you want to just start with some mouth swabs. You don't want to torture a patient, of course. I know they're dying of thirst, but by the same token, if they do aspirate, the that would be much worse down the line. Next, some of you might have heard of VAP, also known as ventilator-associated pneumonia. A lot of patients in ICU that are on a ventilator end up with ventilator-associated pneumonia. And part of that is that they aspirate. That's part of being intubated. Microaspiration or macroaspiration lead to ventilator-associated pneumonia. Now, it is often as a consequence of a neurological dysfunction related to the stroke, altered swallowing reflexes, weak cough, or excessive sedation, right? All of that can play a big part in intensive care. Preventive treatment mostly relies on factors described. And how do you avoid a ventilator-associated pneumonia / aspiration pneumonia in intensive care? Well, number one, avoid excessive sedation, right? No brainer. Problem in intensive care is that if you don't sedate, patients can't tolerate life-saving ventilation. It's a catch-22, right? And one way to avoid it is to use a sedation score and titrate the drugs according to that sedation score. If patients are too sedated, they can't clear their own airway, they can't cough or gag, and that is a risk in and of itself. Next, reintubation is a massive risk in intensive care. So reintubation is definitely associated with an increased risk of aspiration and pneumonia. So care must be taken to avoid unscheduled extubation. More importantly, weaning procedures and timing need to be selected very strictly to maximize chances of success. Clearing of tracheal and oral secretions prior to extubation is highly recommended. Right. So why is this important? I have made videos and blog posts before where I point out that when you extubate a patient, it's a limited time window, and you need to be extubating a patient during that limited time window. So it's critically important that you do that. Otherwise, if you then get the timing of extubation wrong, you might need, the risk for aspiration is real, right? The other thing that's important when you extubate a patient is it's very important that you stop feeds before extubation. You need to stop nutrition so that you ideally extubate, remove the breathing tube on an empty stomach, right? Because if you extubate with a full stomach, the risk for vomiting and aspiration is real, okay? And you don't want to set back a patient. Next, secretion drainage. An endotracheal tube plays a major role in the pathogenesis of ventilator-associated pneumonia. It predisposes the patient to aspiration by eliminating the cough reflex and pooling of contaminated secretion above the endotracheal cuff tube. So timely and routine suctioning plays a vital role here. Next, critically important, maintain the head of the bed at 30 to 45 degrees unless contraindicated. It is now widely recognized that maintaining the head of the bed 30 to 45 degrees is critical in prevention of aspiration in non-mechanically as well as mechanically ventilated patients. In 1997, the Centers for Disease Control, CDC, recommended that these patients should remain in a semi-recumbent rather than in a supine position. This recommendation was based on numerous studies showing a decrease of VAP incidence. VAP, again, standing for ventilator-associated pneumonia. Again, common sense that if you're sitting up, your risk for aspiration and vomiting is decreased. If you're lying flat, just like I mentioned before, 99% of patients in intensive care get some form of nutrition, predominantly enteral nutrition, and 50 mils an hour, 80 mils an hour, whatever it is. You're lying flat, you're in an induced coma, you're turning on your side, the risk for aspiration is there. Gut motility is down, digestive system is down, and swallowing reflex, gag reflex, cough reflex is down, the risk is huge. Okay. And also bear in mind, when you are nursing a patient in intensive care, you're nursing them from side to side to prevent pressure sores, of course. And when you turn them on the side, you can't necessarily put them up 30 to 45 degrees. It is possible, but you got to then tilt the bed. It's a bit of a maneuver. It's a bit of a skill that, critical care nurses need to develop to position patients safely so they don't get pressure sores, but also don't aspirate and still have their head elevated. So seen this many times, that you turn a patient on the side and they start vomiting, for example, right? Other thing that you can throw in the mix, especially if there are issues such as digestion, if they're not absorbing food, patients can have high concentrated feeds, for example, but they could also have medications, regular medications such as Maxalon, also known as metoclopramide, or erythromycin, or a combination of both, to increase absorption, to increase digestion. Metoclopramide, that's what I meant. And that might decrease the risk. Next, surveillance of enteral feeding. Besides maintaining the head of the bed at 30 to 45 degrees, a critical measure to prevent aspiration of gastric content is based on a very strict surveillance of enteral feeding. The presence of nasogastric tube is commonly described as a risk factor for developing pneumonia, because the nasogastric tube is believed to promote a reflux of gastric contents with subsequent pulmonary aspiration. The CDC recommends early removal of feeding tubes, routine verification of their placement, and regular assessments of the intestinal mobility with an adjustment of the administered volume to avoid regurgitation. Again, common sense. For example, if you have a nasogastric tube, what can happen is, for whatever reason, the nasogastric tube might move. It should sit just in the stomach, but it might move upwards, and all of a sudden you've got feeds pouring down into the lungs or into the mouth, and that could cause microaspiration, even with a cuffed breathing tube or with a cuffed tracheostomy. Next, very important, assess for signs of feeding intolerance every 4 hours in tube-fed patients. Regularly checking gastric residuals, the amount of a tube feeding that has not been digested, gastric distension, and complaints of gastric pain are all good indicators of how well a patient is tolerating feedings. Intolerance can lead to vomiting and possible aspirations. Now, for those of you that think, okay, if my loved one is not digesting feed and they have high residual feeds, what are causes of action? Causes of action are, most intensive care units have a protocol. So let's just say someone aspirates 300 mils of feeds. You usually return that and carry on with the rate that the feeds are on. But in other instances, if it's, let's just say 700 mils, you discard some of that and you might only return 500 mils, and you will then start antiemetics, metoclopramide / Maxalon, erythromycin, maybe some Zofran / ondansetron. There's ways of managing that, but it usually follows an algorithm or a protocol. Again, use of promotility agents. Gastrointestinal dysmotility is frequently encountered in critically ill patients, and this culminates in delayed gastric emptying, and that leads to increased gastric residual volume and increased risk of aspiration. Prokinetic agents such as metoclopramide and erythromycin, but also Zofran and ondansetron, are commonly used to improve gastrointestinal motility in these patients. The best aspiration prophylaxis is really not being in an induced coma and on a breathing tube in the first place, and not being paralyzed in the first place. Again, I want to quickly hone in on proning at the moment, because proning is a prevalent option for therapy at the moment with COVID ARDS patients, and therefore, imagine patients need to be fed, and I don't want to go into too much detail why they need to be fed. Everybody needs nutrition, even if they're critically ill. They're burning a lot of calories. When someone is critically ill, they're burning a lot of calories. You'd be surprised. Therefore, they need to be fed. Also, if they're not getting fed, studies have shown in the 1970s and 1980s that if patients are not getting fed early in intensive care, they are at risk of stomach bleeds, stomach ulcers, and the mortality is high if patients in intensive care get a stomach bleed, stomach ulcer. Early feeding prevents the GI bleed and they prevent the gastric ulcers. However, they then pose on the other end the risk of aspiration pneumonia. And imagine if you are in a prone position, head down on your tummy, on your stomach, and you are in an induced coma, you are having a breathing tube or a tracheostomy, you are most of the time paralyzed when you're prone. The last thing a patient like that needs is aspiration. Next, good oral hygiene. It has been shown that the amount of dental plaque increased during the ICU stay and was either present at admission or acquired during the ICU stay in 40% of the patients. Moreover, positive dental plaque culture was significantly associated with subsequent nosocomial infections. Nosocomial infection stands for hospital-acquired infection. Poor oral and dental hygiene is associated with a higher incidence of aspiration pneumonia, oral dental decontamination in general, with 0.2% chlorhexidine gel 3 times daily during the ICU stay, and dental plaque antiseptic decontamination, more specifically, are very promising, effective procedures for the prevention of aspiration pneumonia. So, how to treat aspiration pneumonia? To manage aspiration pneumonia, would therefore first recommend obtaining quantitative cultures taken either from the endotracheal aspirate or protected brush specimen, depending on local protocols. Treatment of aspiration pneumonia requires diligent surveillance for the clinical signs of pneumonia. Treatment decisions are based on 3 factors: clinical diagnosis, time on onset, early is less than 5 days versus late is more than 5 days, host factors, high risk versus low risk. Antibiotics are commonly used to treat aspiration pneumonia, even if the cause is neurologic or chemical. A course of antibiotics will still be prescribed. This is because it's often difficult to exclude bacterial infection as a primary or contributing cause. Invasive, also known as diagnostic techniques such as bronchoalveolar lavage, should be used when the diagnosis is not certain. Antibiotic coverage should be narrowed once sputum culture results become available. Aspiration pneumonia are frequently encountered in ICU. Many studies have been performed to evaluate the effect of preventive measures, and many among those were successful. It is now established that aspiration-related syndromes can be prevented by placing the patient in a semi-recumbent position, close monitoring of the stomach residual volume, providing minimal sedation, and maintaining good oral hygiene. Additionally, the healthcare team, especially the nurses, play a very crucial role in preventing aspiration pneumonia in critically ill or ventilated or with tracheostomy patients. Therefore, critical care nurses should recognize the importance of and advocate for the prevention and for the best possible treatment for their patients in ICU. Like I mentioned in the beginning, reducing the prevalence of aspiration pneumonia will lead to shorter hospital stays, less use of antibiotics, and a decreased mortality for the patients. On the other hand, in cases where your loved one needs to go home ventilated with a tracheostomy, which could be the outcome if someone ends up with in intensive care prolonged, and on a nasogastric tube, gastrostomy tube feedings, your loved one is at high risk for aspiration pneumonia, so they need to be looked after by critical care nurses 24 hours a day, like what we do at intensive care at home, where we employ hundreds of years of intensive care nursing experience who can manage your ventilated loved one safely at home, especially during emergencies and long-term stays. You can check out intensivecareathome.com for more information about this particular service. But also, I want to also quickly mention BiPAP and CPAP ventilation, non-invasive BiPAP and CPAP ventilation, because we're having, one of the main questions we're having is how long can someone stay on a BiPAP machine in intensive care? So, and there is a whole other article and video about this specific topic But when someone is in ICU on a BiPAP with a mask or on CPAP with a mask for prolonged periods, the risk for aspiration there is high too, because high pressures blow into the lungs, and therefore, it's also wind blowing into the stomach, which could upset the stomach. It could, trigger a vomit, and again, therefore, it could lead to vomiting and aspiration pneumonia too. So as much as patients can stay on BiPAP for a prolonged period in ICU, again, you also have to weigh up the pros and cons and the risks. So, and with that, all of that said, I do want to come to an end in a minute. If you have any questions, please type them into the chat pad now, of course. Be very happy to answer them. Now, thank you so much for watching this live stream, and thank you so much for coming on. And, if you have a loved one in intensive care and you need help, go and check out intensivecarehotline.com. Call us on one of the numbers on the top of the website, or send us an email to support@intensivecarehotline.com. That is, again, go to intensivecarehotline.com, call us on one of the numbers on the top of the website, or send us an email to support@intensivecarehotline.com. If you found value from this video, like it, share it, subscribe to my YouTube channel for updates for families in intensive care, and comment below what questions and insights that you have from this video. I will be doing another YouTube live stream next week. I haven't selected the topic yet, but it will be something that's very relevant for families in intensive care. Thank you so much again for coming on to the show. Appreciate all your support. I wish you and your family all the best. And if you have loved ones in intensive care, do not give up hope. Do your research. The biggest challenge for families in intensive care is that they don't know what they don't know. But that's what we are here for, to help you with. Take care for now.